Now, we had words earlier this evening that Dr. Shah might be a bit delayed tonight, but I'm happy to report that India has dispatched of their opponents in 41 overs, and he's here on time to present his talk. Dr. Shah, consultant cardiologist at Southampton. He's the past president of the British Heart Valve Society and also a member of the BSc Stress Echo Accreditation Committee. And tonight, Dr. Shah is going to talk about the importance of using contrast in your routine stress echo practice.
Thanks, Renette, and thanks, everyone. Thank you to Jerome and Gianfranco for inviting me to contribute. I'm just going to share my screen, and hopefully this will work just fine. So I'm just going to go to slideshow. Right, I think hopefully you can see my screen. Is that right? Yeah, perfect. Great. Okay, so I'm going to talk to you a little bit about contrast use in stress echo. So you've seen this already from Martin earlier this evening, and there's a real emphasis on using contrast. Obviously, the 20 structural cases in your 200 in the logbook are not likely. It's very unlikely that any of those would involve contrast. So actually, it's 50 out of at least 180. So I think the point is that and 50 out of 200 is a quarter of your entire logbook. So we're expecting to see that as probably a minimum. And I think, as Martin says, we generally notice that people are using contrast more than this. I think it would be fair to say that stress echo would probably not have survived as a technique and would not survive if it wasn't for the presence of ultrasound contrast agents like Sonoview, because you cannot have a test which has a feasibility that is very low. And contrast means that the feasibility, the ability to actually get diagnostic quality images, is very high. And so that's very important. And we're trying to promote through this accreditation process best practice. And best practice is making your job as easy as possible and making you to be as confident as possible interpreting the images and not feeling like you have to try to cope, so to speak. And I'll show you a little bit about that. So in stress echo, the hallmark of myocardial ischemia is a new wall or a worsening of a wall thickening or wall motion abnormality at stress, which was either not there or was less marked at rest. So if you're going to do that, it's obviously quite clear you need to be able to see the walls of the left ventricle clearly. So if we have a look at this image here on the left, pretty much all you could say about this patient is that they're alive, because you can see the heart is beating. You cannot see any endocardial border here at all. Whereas the same person, a few minutes later, after the administration, of ultrasound contrast, allows you in this 4-chamber view to see thickening in every segment much more clearly. And this is therefore what we need to be able to see in stress echo. So there are quite a few reasons why someone might have poor image quality when you're scanning them. Thankfully, it doesn't happen very often. You might be using incorrect machine settings. I've seen this only happen a couple of times, but the modern adult ultrasound transducers are getting so small that you might incorrectly pick up a pediatric transducer, so you need to make sure you've not done that. There can be anatomical challenges, and these are well known to you all, but there can be a number of anatomical reasons why transthoracic images without any contrast could be quite challenging. So even before you give contrast, there's quite a lot of things that you can do to optimize your image, which includes changing their position, asking them to breathe in and hold their breath or breathe out and hold their breath. Make sure you've got harmonics on rather than fundamental frequency imaging, doing things to maximize your frame rate and increase your resolution, like reducing unnecessary depth, decreasing the width, and adjusting the focus. But despite all of this, you may still have someone in whom the image quality is suboptimal. There are lots of guidelines out which you've heard about for using contrast. It'll improve your endocardial border definition. This means you can do quantification, so you can get accurate volumes and ejection fraction, and you can look at systolic wall thickening in using the 16 or 17 segment model, so you can comment on regional as well as global systolic function. And you can also detect structural abnormalities, for example, the presence of a thrombus within the heart. In stress echo, of course, we're looking for improved endocardial border definition. That has been shown, as I'll come to in a second, to both increase confidence and accuracy of the test. And as you've heard earlier, you can also do perfusion assessment by MCE, which is myocardial contrast echocardiography. There are a number of guidelines out which you can look up on contrast practice. This is the sort of thing, I suppose, that we're trying to avoid. This is an example of trying to cope with the image that you've got, thinking, well, it's just about okay, I'll get by. Well, if you have a close look at this apical 4-chamber here, it is often the case that the inferior septum, the endocardial border, is well defined, and you can see this quite nicely. But you can see here, apart from the fact that this ventricle is extremely foreshortened, you can see here that actually in the lateral wall, you've not got clear endocardial border definition. We know that there's a papillary muscle here with subvalvular apparatus. So where is the actual endocardial border of the anterolateral wall? And this was at rest. On the right, you've got peak stress. I would suggest to you that although you can see the septum here quite well, you really have no idea where this lateral wall is. And of course, this is circumflex territory. So if you're trying to diagnose single vessel circumflex disease, you've not really got much hope if you can't even see the lateral wall. And then if we have a look down here, this is the 2-chamber view in the same patient. Again, highly foreshortened. Inferior wall just about seen, anterior wall not well seen. Remember, there's a papillary muscle here and a papillary muscle here. So you cannot be sure that's endocardium. It's almost certainly pap muscle. Where is the anterior wall here? And then have a look at peak stress. I mean, really, what are you diagnosing here? The person is alive. Beyond that, you would be I would be very hesitant just to call ischemia or no ischemia. But this is someone that's obviously just tried to cope. And what we're trying to say is don't do that. Take the time to give contrast and maximize your image quality. So Renette may well be about to touch on this to a degree, so I'm not going to spend a lot of time talking about the practicalities of contrast, but broadly speaking, you can give a bolus injection or you can give a continuous infusion. At present, Bracco are not manufacturing the ViewJect pump. I spoke to the Bracco rep actually at the EACVI meeting earlier this year in Barcelona, and they are working on an updated or a second generation ViewJect pump. But those of you that have a ViewJect pump like we do, fortunately in Southampton, may still be using this. And you may find it very helpful for a smooth contrast application intravenously. So just a few tips and tricks, I would say. We always use a 3-way tap, small volumes, slow injection. This is not a rapid injection. It's a slow injection. We typically say, I'll give you the pictures to show this. So Renette very kindly lent me her arm about a decade ago when we were working together, and this is her arm that she allowed me to cannulate for these educational purposes. So we typically put a 3-way tap on, so we advise you to use this. We typically would suggest don't give the bubbles through this pink port here at the top. The port is much smaller than going through the 3-way tap. Going through the top here, you're going to make the bubbles go through a right angle. You want to preserve them and not make them go through any sort of trauma. Obviously, you can do this, but we suggest for optimal image quality and to avoid artifacts, it's best not to. We would suggest, again, don't use the side port where the bubbles have to go through a 90-degree angle. Use the end port so the bubbles can go straight through the cannula. And if you're giving this with dobutamine, put the dobutamine through the side port, and the cannula, you can use the straight port for the contrast. So there are many, many papers on using contrast in stress echo, and I'm not going to go through all of them. I'm just going to mention this one because the optimized trial is one of the most widely cited for supporting the use of contrast. This came from Bill Zogby's group in the States. They had patients that were prepared to have two stress echocardiograms with and without contrast, and they looked at segment visualization and they looked at accuracy of the test. And they looked at reader confidence as well. And what you can see was that if you could see all of the segments, or just one or two segments that were not clearly seen, there wasn't a significant difference between giving contrast or not. But when you couldn't see more than two segments, there was a very big difference in reader confidence. And this is what really informed the original guidance on not being able to see, if you can't see two or more adjacent segments, you should use contrast. That number really came largely from this optimized trial. So here's a fairly straightforward example. Whenever I give talks like this, I'm always very keen to show real world examples. I don't always put up, what you might call conference quality, because actually not every patient has conference quality images. But the question is, can you get diagnostic quality images? This is a person with several cardiovascular risk factors who has exertional chest discomfort, and he was sent for a stress echo. On the 4-chamber view on the left, you can see the resting image. On the right, after exercise, you can see that this cavity has dilated, the apex has become spherical, and the entire apical region, apical septum, and this anterolateral area have become akinetic. So the apex has stopped working, the ventricle is enlarged. We can see the same thing in the 2-chamber view, very disturbing images after exercise. The cavity has enlarged, the entire anterior wall is akinetic. So this would be very, very suggestive of significant LAD disease. And the fact that you can see here, the fact that the septum is involved might suggest that the septal branches are involved. So you would guess probably proximal rather than distal LAD based upon this involvement. And sure enough, when he has his coronary angiogram, he's got an exceptionally tight coronary stenosis here, which was treated by revascularization. Now, one of the things that contrast has done is revolutionize the ability for us to do stress echo in larger patients. And we know that our patient population is becoming more comorbid, and we are more frequently coming across larger, heavier patients. When I was working in London just over a decade ago, I remember doing a list where we had 2 patients that consecutively had a body mass index of over 50. And this was the first one. This was a 49-year-old lady that had symptoms, and she had multiple cardiovascular risk factors. Of course, when someone has breathlessness and a BMI of 56, it's of course very tempting to just say, well, it's just the weight. But of course, if the symptoms are new and if they have cardiovascular risk factors, you are obliged, of course, to make sure they don't have coexistent coronary disease. But what are the options for someone like this? Many of these patients will not be able to have cardiac MRI. They may not be able to have nuclear perfusion. They're often very tachycardic and not good candidates for cardiac CT. And actually, at this size, the dose of cardiac CT, the dose of radiation you would need for a meaningful cardiac CT can be really quite challenging. So actually, for some of these patients, stress echo is possibly the only test they can have. And this person here, again, not conference quality, but in terms of what we were able to see, this is rest on the left and stress on the right. We were able to obtain diagnostic images in this person, and we're able to say that actually with stress, the LV cavity gets symmetrically smaller, and we're not worried about myocardial ischemia. And then the second patient came on that list and had exactly the same issue with a similar BMI, and we were able to get diagnostic images. And it made me realize that actually this is probably the only test these patients could have. So at that stage, I thought, well, why don't we have a look at this and we do a study? So we called it the SUMO study, which was the stress ultrasound or stress ultrasonography in morbid obesity study. And what we did in this study was over a 13-month period, this was a prospective multi-center study across 3 hospitals in London. We looked at all of the patients attending for stress echo and looked at those that had a BMI of over 35, which in total was just over 200. And the average BMI was actually much closer to 40. And what we found, incredibly, was that the test had a 95% feasibility, and actually you could get diagnostic images in 99% of patients, but they almost all needed ultrasound contrast. So in people with a mean BMI of 39, you can do the test in almost everybody, but you will need contrast in almost everybody. And we were able to show that if they had a normal stress echo and we followed these patients up, their event rate within the first year was less than 1%, which is what has previously been published with stress echo in normal BMI individuals and in the other stress techniques such as nuclear and MRI perfusion imaging. So this was quite handy, really, in demonstrating the value of contrast in a real life stress echo setting. This is one of the patients. In fact, this was the heaviest and largest patient from that study that I've just shown you. And this is someone that had a weight of 206 kilos and a BMI of 63. This is their resting image without contrast, and this is with contrast. And actually, these are just still images from 4-chamber, 2-chamber, and 3-chamber. And in fact, these images were so clear at peak that we were even able to assess perfusion in this patient as well. So it can be done. And then finally, just to show you that, you know, these are not all just historical cases. This is a stress echo I did personally last Thursday, 65-year-old patient who is again generally quite a large gentleman who has breathlessness on exertion. This is the parasternal long axis at rest. This is the apical 4-chamber. You can barely see the heart. But the application of contrast gave me this image, so I can see the walls, I can see systolic thickening. And then he managed to do exercise. We're very keen on exercise where possible. He did 5 minutes of the Bruce protocol, stopped due to his typical breathlessness. And you can see it's an abnormal study. The apex is spherical. There's hypokinesia here. You can see that's persisting into recovery. And in fact, if we have a look at our 3-chamber view, again, you can see this is at rest and this is after exercise. And you can see that the cavity has not got smaller. If anything, it's slightly dilated. The cavity is less dynamic. The ventricle is less dynamic than it was at rest or than it is here in recovery. And there is essentially complete akinesia almost of this infralateral wall. So again, contrast allowing this test to be done, where without contrast, there's no way we would have been able to do this stress echocardiogram. So I think my conclusions, what I've hopefully demonstrated to you is that it's worth giving contrast. The number of times we see people trying to cope, and actually, you think if you just given the contrast, take the effort to make your images as easy as possible. Contrast is cheap, it is safe, it's very effective in improving your image quality, and it will improve your confidence in calling studies either normal or abnormal. It also therefore makes you more accurate in detecting wall thickening abnormalities. And like I say, we know that if you give contrast, the chances that you will get diagnostic images are much higher, the chances that you will be confident in your images is much higher, and the chances that you'll detect an abnormality are much higher. Okay, thank you very much.
Thank you, Benoy. I realize that nobody here tonight probably needs convincing on the value of using contrast in stress echo, but it's still nice to see it illustrated so beautifully. I do realize we're running over time a little bit. I hope you'll stay. I don't think we are going to try and cut the next 2 presentations short. I think it's important that we cover the topic and give it its justice. If we run a little bit late, I do apologize. And like I said, I hope you'll all stick around. We might be able to squeeze another half a point out of the BSc for your attendance.